Allison Agwu, and I do adult and peds infectious diseases. The large majority of patients I take care of are adolescents and young adults. But being med peds, my clinic, I often say I see patients from the cradle and I try to prevent the grave. I really do have the whole spectrum, but the group that I'm passionate about are adolescents and young people. So I just think we can do better to have them optimize their lives and health and just outcomes overall. So that being said, I would love for this to be interactive if possible. You can unmute yourselves and we can have it be a dialogue. And if it gets crazy, then they'll tell me that it's crazy and we can't do it. But you can either just raise your hand. So it'll be great if I can see you, then I know who's there and who wants to say something. We have about 33 people on. And so I got a lot of questions during the chat, during the talk that I think that many of you may have input on what you do at your places and that may help each other. So with that, I will stop and say, were there any burning questions or comments people had during the presentations or around the presentation? I'm going to unmute you guys. So if it becomes a cacophony of noises, then I'll have to remute you, but let's try it. Okay. And again, you can mute yourself if you have a chainsaw in the background. So any comments or gestalt reactions after or during the talk? Okay. Do you all feel like you're expert at taking sexual histories for adolescents? No, no, I think that's true. Maybe I'll go through some of the questions, and I am not the authority. I think we all have different approaches that we take for young people, and would love to hear people's input and things that they may do differently, particularly if they had a response that was different to mine or an experience they thought went really well with an adolescent or young person. So one of the questions that I had during the presentation was, do you believe all your patients really tell you the truth about anal sex, or do you just screen anyway? So maybe I won't start. I can call on people too, because I can see your names. I don't know. So Sharon, do you feel like they tell the truth, or what do you do? What's your take on it? You screen anyway, trust no one?
Okay. I don't have adolescents. I'm 18 and up, but it is kind of one of my questions. I find that in the 40s and 50s, I can't still always trust they're telling the truth. By 60, I feel like if they're not telling me, they know what the risks are and really understand. And I get caught with the whole Ryan White, that funding, the annual RPR, and when somebody's 70 and they have a single partner or no partner, and I believe them, I don't think it's necessary, but I would say in their 20s or 30s, I do find that they're not completely honest.
Mm-hmm. Yeah. So it's interesting. I will say this, that my oldest patient that I took care of was 70 when she was diagnosed with HIV, and nobody had asked her. That generation, as I get closer to it, I have to be careful, but the things that they had to worry about when they were younger are very different. And so they're worried about the clap, or they're not worried about pregnancy back then. And so if they don't have those things to think about, then, oh yeah, they don't feel they need to disclose, or they're being safe, and they don't have necessarily the same assessment of risk. And so we do need to ask and and they may be embarrassed about it when they ask. I'm actually going to do a talk in September on sexual history taking across the age spectrum, because we do see that little spike in later ages as risk perception is different. The clap is very different than HIV or syphilis. So I'd push you a little bit to challenge them. And particularly when 50% of marriages may have some infidelity in there, and we say, are you married? Oh, I don't need to check. Well, we are often pleasantly or unpleasantly surprised about how much is going on.
Oh, no, asking is one thing. I'm okay with asking. And then, is there honesty really there?
I think we're oftentimes a challenge, because social desirability hits us all. I don't know if there are other comments on this from other people. Do you screen anyway? I agree. The young people are, they are very challenging. And so we just make it part of annual, this is your screening. This is what we're going to do. The 18 to 24-year-olds are even more problematic than even the younger ones sometimes. So just screen across, just keep going. All right. Anybody believe them and just take a, oh, I'm not having sex, as, okay, great, we'll keep moving.
I find it's a couple of things. One, with younger clients, you know, your 16, 17-year-olds, it's really an issue of trust. How much they trust you is going to be how much they're going to answer you. And sometimes that takes a little bit of time to build up. It's not going to happen the first visit.
Yep.
Case in point was a 16-year-old who was newly diagnosed in the hospital, constantly surrounded by his parents, didn't want to come out to them that he was gay or MSM. And it took a few visits before he finally admitted, hey, I never slept with, you know, men. And it took a few visits before he really became honest or comfortable enough in disclosing some of his sexual history and sexual practices. And then the comment about the older folks, you know, it's amazing. A lot of us, I don't know, I guess we don't want to picture our parents having sex, but is maybe part of it. But, you know, I've had older clients, a 62-year-old who was basically celibate. He said he was celibate. We did the annual RPR, voila, it turned out positive. Oh yeah, I remember now. I picked this young guy up when we were looking at the cantaloupes at at our local shopping market. So, you know, it's funny with it because I tend to believe most of what my clients say, but I also know there's a trust issue there.
No, I agree. I think, you know, that's part of why I mentioned that it's not a one-time thing. It's starting and always providing a place to talk about it. So even though my at 10 or 11, they may not be sexually active, but starting questions about your body, do you have questions about this? And making it a permissive space, and that goes for no matter what age range. If it's a permissive space, people are more likely to step into the space. If you have that very clinical and I'm going to address X, Y, and Z and not seem like you're ready to talk about it, they're not going to talk about it with you when it comes up. So I think you're right. Body language, cueing, really trying to just take their cues, but pushing a little bit as well, and saying, oh, well, whenever you do, I'm here to talk about that, and being, you know, and not being surprised when they do, you know, not having your hand on the door either.
Well, and that's the other thing is, if you're uncomfortable what their answer is, then they're not going to talk to you ever again.
Absolutely.
If they feel that you're just there to check a box, they're going to tell you what you want to hear. But if they actually are honest and say, hey, I'm having this relationship, and then this look flashes across your face like you disapprove of that, whatever that relationship may be, then you've lost them. They're going to be quickly to kind of shut down with you.
Exactly. And I think, you know, it's verbal, but it's also very much on nonverbal interactions, the raise of the eyebrow, you do what with what, and then by definition, you have created this stop. Don't talk to me about that. I'm not the person. And by, you know, you're going to lose your opportunity to intervene and interact in the future. Another question we got was there's some data that reporting oral and anal sex is not always congruent with reality. So what do you recommend regarding extragenital screening in teens who do not disclose? So you're absolutely right. You know, the non-traditional methods of having sex, people may be less comfortable talking about. And so if you don't ask about it, one, they definitely won't talk about it or know that you're open to talking about it. Extragenital screening is not necessarily blankly done to everyone, right? So, you know, we think about urine-based testing and then asking about the questions and then following sites. But if you are open in how you ask the questions, and so, you know, where do you like to have sex, right? Then you may get actual locations on the beach, under the bleachers. You may get that, or what? And I even have asked, well, what orifices or what holes do you use? They're like, Dr. Agwu, okay. You know, then they start to open up because they realize that you're willing and able to talk about it. And then with that, you say, okay, and you say, I'm not just being in your business, even though it's interesting to be in your business, but I do want to know because it helps me know where I should actually be screening for you and where we should test. So then you're being voyeuristic, but then you tell them why, and then it becomes an exchange. So it's normalizing it. And if you ever say, you do what? That's it, done. right? So being very open to what you talk about. And then not just screening, but then being able to say, okay, so with that, here are the different modalities you may want to use to protect yourself for that. You know, let's talk about that wet to make that, you know, that lubricant that makes it easier to do that, or, you know, more pleasurable to do that. You have to be willing to take them down the whole path, because someone mentioned during the talk, the additional P is pleasure. And part of why young people are doing it is there's pleasure. And we've got to get comfortable with the idea that there's pleasure is related to it too. And if we're just uncomfortable with that, they're going to be uncomfortable with that. All right. Anybody have any other approaches to extragenital testing? Anybody do it blanketly across the board? I can't see the people who can't see, so you have to raise your hand or something like that. Sarah, do you do it across the board?
I do, yeah. We do like a triple screen on all of our MSM patients every visit, and they know, and they sort of, I think, look forward to it and want to make sure we check all sites.
Yeah, definitely. I mean, so, you know, I presented, we're going to do X, Y, and Z. And there's some young people who are like, okay, listen, Dr. A, I am exclusively a top. I don't want anything near my anus. And, you know, and they're honest about it. Like, I don't want anything near my whatever. And that's it. Like, all right, so I won't do that. But I do, particularly for our young MSM, which is where the extragenital stuff testing is positive. I say, we're going to do all 3 sites until you tell me otherwise, right? I think it's important. Okay. All right. Another question that came in is about PrEP. And I recognize that people are from everywhere. And I would really love to hear people's thoughts about PrEP, in particular the access issues for adolescents. And so the specific question was, I know PrEP is a bit of a gray area for adolescents when it comes to providing without parental consent based on state law. Any resources or advice for states that have not explicitly added PrEP to the legislation? And so I will preface this by saying I'm in Maryland, but really most states have laws that allow adolescents to access prevention, testing, et cetera. Whether or not they specifically state the PrEP word in there can be variable. And so I would love to hear from people who don't specifically have the PrEP sort of covered in their laws, and how they're approaching it. And I'm happy to share ours. Anybody not particularly covered, PrEP not covered specifically, and maybe giving some tips about how they're managing it. So that means we're progressive, right? So I think even before—
No, we're not progressive.
Okay, well, go on, Jeffrey, let's go. So what are you doing?
Well, we're in the rural South, in a very rural area, and PrEP in our district, we're with the health department system here, and PrEP in our district is non-existent as far as most cases. There's some at one of the large local colleges in our area. Our district covers 8,000 square miles, so we travel a lot. But the problem we have here is we're trying to incorporate it in our STD treatment centers in different districts, or different health departments rather. But, you know, there's a lot of issues. One, nobody likes to fund it. I know, and when you start getting into young people, somebody mentioned their insurances. A lot of them are covered by various different insurances up until the 18, usually in the state of Georgia. So, and I just doubted myself where I'm at. But anyway, so it's very difficult in that we can, you know, we have the rules that if somebody over 13 comes in and asks for treatment and pregnancy treatment and that sort of stuff, we treat them. There's no questions asked. If they're a little bit on the younger side, there are some questions asked. But as a general, we have. But PrEP is not specific, like I said, mentioned. So it's very difficult, especially in our most at-risk youth who aren't living at home anymore. They don't have a guardian necessarily. They're living with not relatives, but potential boyfriends or girlfriends or partners' families. And so then if you start asking about permission in that specific instance, because it's not actually treating, it's prevention, it gets very knee deep. So that's why I was hoping somebody else may have some suggestions that also is from rural or semi-rural areas.
Anybody else from not Georgia, but any other rural areas that would love to comment?
Well, to piggyback off of what Dr. Dockery said, we are also in a rural part of Georgia. There you go. We'll out together. You know, PrEP is still fairly new in our district as well. And we see clients down to the age of 13, but the majority of our population is in that 17 to 29 age range. And PrEP is still really new to us. And so even if it's new, getting it to adults or older adolescents, then I'm sure even in younger youth, you know, it's harder for them to access it as well. So I was kind of interested to see if anyone had any insight to that. Because we have a teen clinic as part of our health department, but PrEP is not on their services.
So, I mean, I think, and please, if anybody else is from that area or which happens to be in the area that overlaps or overlays or is right in the thick of the end in the epidemic area, right? So we need to think about how we can do this better, because, you know, the Deep South is deep purple or deep red, depending on what map you look on in terms of prevalence and rates and et cetera. And young people are acquiring infection, and we're missing opportunities. And so I think certainly before it was explicitly in it for us, we were in Maryland, which is also in the areas, we were one, I shouldn't make it seem like we're excluding parents. I mean, we definitely are trying to have adolescents bring in those people that care about them, who they trust, right? And so if we can get them, we try to encourage parents to come in when it removes some of those barriers. But if not, we're trying to figure out how to best use the Gilead access programs. We're trying to figure out ways to use program income from Around White to pay for some aspects. But you're right, it's challenging, and depending on where you are, what you can and can't allow. There are some new changes now. Our PrEP program or EIS is now going to be under our Ryan White program, so perhaps we'll be able to do some of that. And so I think there's recognition with the EHE funding and with the ask of that we're going to need to think about this better if we're going to really move the needle in terms of new infections. But admittedly, it's very challenging in some places, particularly if there's a big disconnect between where we need to be and what we're feeling comfortable or able to do. Any other comments on that question? It's a tough one, and so you guys are not alone in Georgia trying to navigate that. It's across many areas, and even when it's on the table to be done, we're still having providers not do it because they're expecting somebody else, so infectious diseases people to do it or someone else to do it. By that time, we've missed the boat, right? And so we need to think about how we do this better.
I'm sorry. I would also.
John.
Yeah, I heard. Who was that? I heard it.
Go ahead, Tara. You go ahead.
Yep.
Oh, thank you. I would definitely look into a Gilead assistance, patient assistance programs. We fund a PrEP patient navigator, which has been great for our clinic, and they outreach into the community. They go to schools, they go to colleges, they go to voguing events. You know, they go out in the community and try to reach people and link people back. So a PrEP navigator could be a good position, and also see if you can harness the power of 340B funding, if that's something that is available to you or your clinic, because that's a really nice way to utilize those types of funds for that purpose, because obviously, especially in someone who's uninsured, it is not cheap.
I think John Nelson had a comment or a question. John?
Yeah, thank you, Dr. Agwu. I was just I'm a nurse practitioner and am currently with the AATC NCRC, but prior to that worked with adolescents since 1989 in New York City and in upstate New York with HIV. So I am testimony, everything Dr. Agwu said this morning is correct, and we've been trying to do that for many years. One of the things, I'm a huge advocate of homeless youth. We have just so many, for such a wealthy country, we have so many youth and children that are on the streets. And that one of the things that in every state, as we know clearly, every state has the right to do what it wants. So we don't have any national rules against this. But generally, if a youth has been out of their home, I mean, a minor under 18 for 6 months, they're pretty much considered autonomous for making their own decisions. So if they've been able to support themselves through couch surfing, through transactional sex, whatever they're doing in most. But what I wanted to say is to maybe for those like Dr. Dockery, is to get a hold of your ACLU and or the HIV Law Center, which is in New York, and they have some guidelines and rules for each state, just so that you can document in your document providing this care to a 15-year-old or 16-year-old who does not have a parent.
Yeah. So I think it's, thank you, John. So I think definitely knowing your state laws is really important. I think the Guttmacher Institute does a sort of a updated sort of real time what laws are and chronicles that. I think that's where that is, and I'll verify and share. And so just knowing what you're protected about, what the youth's protections are, they need to know, and what their rights are. I think just doing that and making sure we're up to date on those are important. But I think the reality is most states do err on giving kids access. It's just whether or not how our systems logistically work along with that, right? If we can get them in play. And this is it's an issue for PrEP. It's going to be an issue for injectable PrEP. So it's not going to go away. And so we need to figure out how to do that. There was a really good question about Title X funds. Do people know what Title X funds are? Go ahead, Sarah. You're shaking your head. And I'm sorry I'm picking on you because you're in the middle of my screen. So when I look, I see you. So you can tell people what Title X funds are.
So I think we actually just decided not to renew our Title X funds because I think we were getting funding. It ended up being like a double dipping, but I believe that we were using it for family planning, right? Yep, it's like exactly. Family planning funds. So we used it to hire a family planning specific MA and just do like, she was able to do like STD treatment, follow-up, referral to city, funding a lot of like our, those types of like family planning things. But yep. we already, I think with Part D, we had like an overlap. So we ended up deferring it back.
Okay. So yes, Title X is a federally funded program for basically family planning, reproductive health services, STI prevention, treatment, and for anybody, and you can apply for those funds. It's been in the news as of late because there's been some attacks on Title X funding trying to limit what you can do, restricting the services available and the funding. And it's interesting, as we do EHE and try to expand HIV treatment and prevention, we cut down Title X funds. It's this bizarre paradoxical relationship, but our clinic was lucky enough to have it, which allows us to do a lot of, again, prevention, treatment, et cetera. And it's complementary to PrEP and everything else that we're doing. So if you have the opportunity to apply for those and you don't have funding that would overlap with that, then certainly would suggest that it does expand your armamentarium. Want to underscore the whole idea of a PrEP navigator. We oftentimes think about the HIV continuum and how the HIV continuum is terrible when it gets, particularly with adolescents, going from diagnosis all the way to treatment and suppression being really low. The PrEP continuum is probably even worse in terms of individuals who are eligible for PrEP, actually getting on PrEP, actually staying on PrEP in terms of maintenance. And for adolescents, we know that adherence can be terrible for many of the reasons that we talked about, cognitive and development and life, et cetera. So them staying on PrEP can be challenging. Unfortunately, we've had the sad state of having kids that we've prescribed PrEP and didn't stay on, and then we're doing the HIV diagnosis. And so PrEP navigators and outreach specialists and just being purposeful about following up and supporting kids through PrEP is really critical. So not just writing that prescription, but then following up to see what happens to make sure that it ends up actually protecting them. Okay, there was another question about bone density and impact from PrEP for adolescents, which I think is actually important. So in terms of supplementation and calcium and vitamin D, certainly it doesn't hurt. Oftentimes when you look at the PrEP studies for adolescents, many of the adolescents, and this is all young MSN, came in with lower bone density just because I think it's a higher proportion of African Americans where vitamin D levels are lower. There's weight bearing exercise lower, some of it's maturity to age lower. And so do think about it. Oftentimes I recommend they do it. They're going off and on it sometimes so often that it's just one additional thing for them to remember to take, which I worry may affect their adherence. But certainly do offer it, particularly if they're going to be on it for a long period of time and are being adherent. there was a really good question about sexual abuse and how do we approach this. And I don't know if that person is on the call, wanted to elaborate. The way I took it was that if I suspect or there's concern about sexual abuse when I'm doing a sexual history or interacting with an adolescent, how do I approach this? I'm assuming that's the question. Not sure if they're on here. So we're all mandatory reporters, and I think this may be related to when I do my confidential, confidential counseling with that youth. I do tell them that if they tell me something, that would be one of the things that I would have to report. So you do tell them that it's confidential, but if they told if they are going to harm themselves or there's something concerning, you will have to report. And that may decrease their likelihood of telling you, but you also don't want to break their confidence if you then tell them. If you tell without telling them, you're going to have to tell if they tell you that. Okay. All right. I think I answered this one about universal urine testing for GC chlamydia, and we also talked about extragenital testing. There's a really good question. A lot of these questions are about PrEP, which makes me excited that people are asking all these questions. That means that you're thinking about PrEP because it's something that we can do to intervene transmissions and acquisitions. So I find adolescents not being as accepting as HIV. Post-exposure prophylaxis as adults, and any tips? Thank you for reminding me. I did not bring up PEP during the talk, but absolutely, if you're talking PrEP, you should be thinking PEP, because you do certainly have situations where adolescents tell you about something that may be increased, an encounter that increased their risk of HIV acquisition. PEP has been challenging in that you're right, adolescents are hard to get to agree to be on PEP for a number of reasons, even when they could benefit from it. And also we make it hard for them to be able to actually access PEP, because we say, all right, you were in this encounter, we concerned about PEP, now go to this pharmacy, find this out to get this, until we create the hurdles. So a lot of what we have in place or try to is to work with our pharmacies. So if an adolescent is identified to need PEP, they better leave that clinical space with the PEP in hand, with the outreach specialist who's able to follow up with them, with the plan for what to do, with the bat phone of who to call, to make it as easy for them to then follow through. So explaining to them what the risks are, and they hear part of it, but not all of it, but really, encouraging. It's now easier because we're doing one pill. It's not that you're giving them Kaletra and all kinds of things that made them sick. So it's easier than it had been in the past, but it's how we then make the logistics work for young people, and actually for anybody, but particularly young people where there may be challenges to go get that $3,000 prescription for the month for the PEP, right? So we have to figure out how to make it work. Other comments about PEP before I move to the next question? Are people doing it for adolescents? I see a maybe. You guys are my brave ones. I'm gonna start calling people. What about Karen Lee?
Yes, say yes. Yes, because
yes.
the other issue is that they may come in and say, I want to start PrEP. And when you find out they had unprotected anal intercourse 4 hours before that. So you got to start them on PrEP, get them to PrEP. So happy that they came in within a couple of hours to tell you. Right. So that's the good news. But yes, PrEP is important.
And I often we talk a lot about the challenges with young people, but the resiliency is actually something we should celebrate, right? For a young person to come in and admit they had sex, they had this, and to actually, let's give them kudos for being able to do that. We oftentimes are beating them up for spreading COVID or doing all these other things, right? But giving them the kudos on what they actually do well, and promoting that and encouraging them, I think, is really key. And it's hurdles a young person has to come in to do that. So that's great that you guys are doing that. Okay. Let's see. I actually really want to hear about people. I'm going to call on some people down there, because I know what we do in terms of our practice, in terms of having time for these interactions about sexual history. A lot of our appointments are half an hour, and we could even have 45 minutes or an hour appointments. I get that there are some places where it's 15 minutes or 20 minutes. And so struggling with how to get that sexual history in, and not just get it if you get a response that means you have to keep exploring, having the time. So maybe I'll ask a brave person who feels like they don't have enough time, and what they think may be some strategies they can use to increase that or address that. Maybe someone who hasn't talked. Lynette Johnson, how are you doing that? See, she's gonna stay on mute and hide. No, but really, not to call on anybody, but what are people's thoughts of how to optimize sexual history taking given the limitations on time? Anybody? Go ahead, Megan. Thank you.
Hi, so I'm in Sioux Falls, South Dakota. I'm actually a nurse case manager for the Ryan White Part C program. And for my provider, we did start doing I don't want to call it a survey, when they fill it out before the appointment. So the nurse goes in and rooms the patient, and then they're given, gosh, what questionnaire, I guess? It's a sexual health questionnaire. Yep. And it allows them to just kind of personally fill it out. And the doctor has really appreciated that.
Yes. Really good point. So yes, I didn't mention this, but yes, absolutely. And that questionnaire, so we have a survey that adolescents fill out. Some people have it on paper. Some have it even like an iPad or that they can answer questions. And so you're walking into the appointment already knowing if they're gonna be admitting that they are, right? And it's already there, so you know to address. So I think it's a great point. Using tools that we can employ in our waiting rooms, et cetera, to get those questions. Great point. Anybody else doing anything creative to sort of help garner those questions and to prompt us and help? All right. Is that Coley? Am I saying that right?
Yes. Hi. I'm in Connecticut. I don't know that it's like mind-blowing or anything, but we have an MA who rooms our patients, and she is part of the community, lives in the community and all this stuff, and they tell her everything, like everything. She's in there longer than we're in there. Right. And then she will come back in after rooming them and give us a rundown on what's going on. So then we can just open the conversation, kind of already knowing a little bit of what's going on with them, because she is just a gold mine of information. And they will tell her stuff that they won't tell me and they won't tell other people. Yeah. But if I know it going in, I can just say, oh, so, Crystal mentioned that you mentioned, what's going on with that. And it's an icebreaker. Absolutely. And then the trust is built with us also. But I would say, mine, like the nurses and the MAs to help you too, because they see them longer. So yes. they have that relationship.
So I think that's a great point. So thinking, oftentimes we think about our 20 minutes or 30 minutes as all the time we have, recognizing that there's a whole period of time in the waiting room. There are other people who can interact that also can provide us information. And so there are extenders, use them. And a lot of times there are, again, from the community or just the rapport is different and the kids may not be as worried about disappointing them or worrying them. And so they will share everything. And so then you come in like, don't you know, Dr. Agwu? Well, since you asked, and then they go. So I think that's a great point is use your whole team, making sure the youth know that what they share with that person will come back to you, and that's okay. We're all part of the team. So definitely great. I see Lynette apologizing because she was on the other side of the room. Did you have anything you wanted to add, Lynette? She said that, yeah.
So I'm a nurse, an HIV nurse, and we only in my clinic are working with 18 and older.
Yep.
So I do think a lot of what I'm hearing though really works across the age span. I can't tell you how many 50-year-olds have, I've had to answer these same, work with these same questions. I think in our clinic, we are really blessed that our physicians and our nurses have a lot of time with our patients. And I know in some clinics that's not the case. So we are able to really delve into all of these sexual histories. I think it takes a lot of practice to get that. And we really work even with our fellows, working with this, which is something that I don't think a lot of practices do, really training up the new doctors to do good sexual histories.
Yeah. So unfortunately, I think you're right. And the problem is it's not just in our practices that we're not good at that. In our schools, we're not good at that. There's not any venue where we're doing a great job with that. I mentioned that I have a 13-year-old and I had the opportunity to be part of her 5th grade sexual, introduction. And I was so excited. I'm like, let's go. I went to talk to the class 2 weeks after they've been talking about sex in school. So I'm like, yes. So I'm a class of 30, 11-year-olds, and they're like, gonorrhea and chlamydia. I'm like, oh, great. And they're speaking in great terms. So I said, okay. And pregnancy prevention. And I said, okay, so how does the sperm get to the egg? Crickets. They didn't know. So they did gonorrhea prevention, sexuality, condoms, etc., but they never covered what goes where. So here I am in front of a class of 30, fifth graders, like I'm about to blow their mind. But these kids were told to ask a trusted adult. So you're teaching them about sexual health, etc., and you're telling them to trust a trusted adult, ask a trusted adult. And so, I said to the teacher, well, you know what? I happen to be a trusted adult. But it was interesting because there was variability in terms of the kids. And so there we can have an age appropriate, well, you talk, you have a penis, but that's what is happening. And so if we don't have those discussions, we don't know how to take a history, then we're not arming our kids. The youngest kid, I oftentimes say this because I feel like it was such a missed opportunity. The youngest kid I diagnosed with HIV was 12. He started having sex when he was 10. Right. And, when we finally got comfortable, I think Joffrey mentioned young person, coming in and not till the fourth or fifth encounter, really admitting what had happened. And he's like, Dr. A, I know you've been asking me all these questions and I'm good with you. He's like, nobody abused me. Nobody did anything. I started having sex when I was 10, my brother's, friend or whatever. And no one ever asked me to use a condom because they never did. Right. So there we go. And so starting to even talk about these things in age appropriate, and someone asked what's age appropriate. I think it's making kids comfortable to ask questions about their bodies at a younger age, and it builds with that. Right. We can't just start mentioning you have a penis at age 13. Right. You have a penis at age 5 and 6, and then it builds from that, and having that comfort with both the kids, but also letting the parents know that we're going to have to start talking about some of these things because they have questions. And if it doesn't come from us, it's going to, most kids are learning about sex from porn or from friends, et cetera, and they're going to get the wrong information. So we have to look at it as our job to intervene with that, at multiple levels. So yeah, that's my little soapbox on that. Okay. Now, in terms of sexual health questionnaires, someone asked, do I have any good sexual health questionnaires that I would recommend? Megan, you mentioned one that you guys are using. Do you know what the source of that one is? Curious?
So no, what I did actually is I think I Googled it and I found one and then I just mocked it up. Like, okay. I just added to it. I want to say it was like the Chlamydia Coalition of California or something. I don't remember exactly, but
okay, no worries. So I will share, and I'll get to the organizers. I mentioned Advocates for Youth because I think that that's a great organization that has youth involved. And so the youth giving feedback on how to ask these questions, and they vet all the questions and questionnaires, and they have links for providers, for patients, et cetera. But SICUS, which is Sexual Institute something, Education of America or something like that, also has some, but there are, AAP has some. So I will share some resources that, you can use and pull to kind of help you construct and even practice in the mirror how to say it without making your face a funny way, but definitely we're happy to be sharing, and not too long, but enough to elicit the information. Okay, let's see. Someone asked us during the presentation about getting parents to leave the room during the confidential part or questioning with adolescents. Has anybody had an experience where they've asked and a parent refused to leave? Curious.
Yes.
Oh, what happened? Do tell.
Well, it was the mom. The young man was 14 going on 15 years old, and she just really didn't want to leave the room to ask him anything. And so he's sitting there very embarrassed. She's there like, well, what did you want him to leave the room for? What do you want to ask? I mean, even into the physical exam portion, I get, in my young men, since I'm a guy, I don't necessarily always have a female escort in the room doing a hernia check or whatever. it depends on the comfortability of the youngster and their age. Sometimes if they're young, of course, mom stays in there and they avert their eyes, but this was a large football playing 15-year-old. So it was kind of a situation. So I kind of, I asked, has he been having sex? And he said no, and that his mom looked very pleased, and we kind of left it at that. Now, did I believe in the word he said? Probably not. Right. But, you know, sometimes it is what it is, I guess. But you look for those opportunities when he comes back, when he's able to drive and he's 16, and all of a sudden he can come to the clinic by himself with a sore throat or with another question. That he came to the clinic. This is when I was doing private practice up to a couple of years ago. But he, when they come back in that without mom, then you can kind of ask the questions.
Yeah. Okay. Others on how to handle that situation, or people had any unique situations where they've had to deal with that?
Well, I love advice on this, actually. I only take care of adults, but sometimes I see partners in the room, and I find that that's very difficult. And they say, oh, well, there's nothing I wouldn't say in front of my partner, but they're saying that because the partner's in the room.
Correct.
And especially with women, when I want to screen for abuse, I worry about it a lot. And with telehealth now, with so many things being transitioned to telehealth, I worry too, because people are in the room with them when they're on the phone. And I hear these sort of like soapbox answer. Yeah. Okay. And then I say, is someone in the room with you and you can't be honest? And they say, yes.
Right.
And I feel like I'm like really stuck and limited in my ability to understand what's going on right now.
Yeah. So I'll take the first part first. I think, you know, certainly for partners, for definitely for kids, we just make it, and I say kids, and I'm talking through 25. I think of as kids, so it's it's okay. But we post it as a policy. We state it up front, so we try to set that up again early as an expectation. This is going to happen, and so at 10 is when I start to give kids, like, you're going to have it, and it's just a standard. And so the family starts to expect it. That's going to happen, and the parents like, oh, I'll go make the appointment when you do your time together, right? And then I also will ask the young person in our time together, are there parts of this that you do or don't want me to ever mention to mom? Or like I ask, sometimes they actually need help to navigate a conversation with their parents. So I'll say, is there some of this that you want to talk to mom about? You need me to help you navigate that? And then it sort of brings us back together. And they say, yeah, you talk to them everything except for my friend smoking. Okay, you know what I mean? And they'll give you permission, and that sometimes is great. In terms of partners, I don't make it a choice. I say, we will talk by yourself as well. So thank you. And then I'm going to kick you out. That's just it. It's because you're right. The IPV and a lot of the things that are going on in relationships, you cannot garner when the partner is in the room. We've also had several situations where we've had partners come in and be together, and then they break up, right? And then that creates a whole nother layer of drama. So, and then they're concerned, well, are you going to go back and tell my partner this? So we just set it up. This is your time, and it's great to have you both in the room, but you each are going to have your individual time. Example, I'm taking care of both partners. You're right. Telemedicine has its perks. Our attendance rates to appointments has been amazing, particularly for our young people. But I think there are some unintended consequences, like people not going to get their labs done. And privacy is another one, where you're talking with them and you can see the other person in the room, and you're like, well, are you able to talk about it? And like, yeah, I can talk about everything. And so really trying to, we're starting to ramp up in-person visits and trying to get people in to follow up if we can, or asking, hey, can you go someplace by yourself so we can make sure we talk. I text a lot with my young people too, so even if we're doing that, we do some texting too, or what have you. Donna, were you going to say something? Oh, okay, I think she was on. So yeah, it's challenging, and there's not a one size fits all. And so trying to recognize, like, telemedicine has been good because I've been able to see environments, and certainly see what's happening in a home. Like, oh yeah, open your fridge for me. Oh, not much going on. Let's get you connected to this resource, etc. But there are some concerns about confidentiality and things that I think we're going to have to work out moving forward. Okay. Any other comments on that? How to address that, because it is challenging.
It's not just telehealth, it's also telephones. Recently, 2 weeks ago had a newly diagnosed 20-year-old who was admitted to our COVID unit because he was having fevers and other symptoms. And in the meantime, they did an HIV screen because he was having this lymphadenopathy he'd been having for weeks. And so they're like, well, you need to go talk to him, because I was working at the hospital that weekend. And I go in and I'm talking with him and asking about risk factors and HIV, his sexual history. And in the midst of all this, I didn't know his mother had called on his cell phone and was listening to every word I said. He didn't tell me she had called on his cell phone. So after she hung up, I'm like, I'm really sorry. I hope I didn't say anything unintentional. He said, it's okay. She didn't hear the sex talk part, but she knows about the HIV. I'm like, well, okay, thank you.
Interesting. Well, I think that underscores, right, that, the HIV, in this household, HIV is maybe better than the sexual identity, which is a challenge, and underscores the stigma and things that many of our young people are dealing with. Erin, I think you had a comment.
Yeah, I was just going to follow up on what Dr. Schultz was saying about an incidence of abuse. We had a particular case where we had a female come in who was transferring care to our clinic, and her partner was not positive. But we, through our process, they see case management first and then nursing, and they were kind of picking up these strange vibes from him during the whole time because he wouldn't leave her and he was very possessive. And so they kind of honed in on an opportunity. So when she went for her labs, we were able to pull him away to ask him about some arbitrary things just to kind of separate them. And then from her labs, they pulled her away so that we could talk to her privately. And, it was just trying to find that opportunity to get them apart, because in an abuse situation, obviously it's very fragile.
Yeah. Yeah, no, I think you bring up a good point. I mean, I think certainly, and this is some of the challenges of telemedicine, is that we don't have those opportunities to, one, read body language and cue, particularly on the phone, like Jeffrey mentioned, and you don't have those spaces then that create separation from that partner. And you're right, there are the partner that is there and is reviewing everything and answering the questions that are red flags for us. And so I again, unintended consequences of all this COVID and telemedicine, et cetera, I think are going to be things like that. And we've seen abuse rates go up. We've seen, for both domestic or IPV as well as child abuse. So you're right. And I think, being attuned to that and then creating follow-up, et cetera, and using the opportunities to blink twice if there's something going on, or just ways that we can pick up on the cues to get people the help they need. I think are really important. I actually do want to follow up on a couple other questions that people had. There are several questions about eliciting gender identity from younger adolescents presenting in the office with possible gender non-conforming clothing and behaviors, and do I have a script for that? And I mentioned in the talk, I don't have a script for that, but I do have it's sort of picking up on that and saying, this is, luckily they're showing me this, but there may be many that are not showing it because they don't feel like it's socially acceptable, right? So they may be the kid that presents as hyper-masculine, but because they're having issues with their identity. And so being very universal in our testing, how are you thinking about this, and who you're attracted to, and those kinds of things. And then if you don't feel equipped to answer more of the questions or help youth guide through that, referring where you can. There are also some resources, again, ScM, Advocates for Youth, and some of the AP that I can happy to share with people about what kinds of questions to ask. And some people had some very good ones. What are the genders of your partners, and who do you like to sleep with, or who you're attracted to, and some of those things that prompt, or tell me about your partner, or your ideal partner, your dream partner that I'd mentioned. And then how do you see yourself? How do you identify yourself? Male, female, etc., he, she, hers. And people at first, some may be like, Dr. Agwu, what's wrong with you? Why would you even say that? But the ones that actually are having those questions or may have this relief, like, well, I've kind of had, and then there you go. You've just opened the door and here it comes. And so we oftentimes are the barrier to that. The youth are okay, and particularly the younger generation where it's been more of that, they're discussing it openly. They're more comfortable than we are often, and I'm telling my age, being older, we're more uncomfortable addressing it. They're much more comfortable talking about gender fluidity, et cetera, and so following their lead. All right. I see John in the chat saying he has some great resources to share and putting his email. So if you can copy and paste his email and shoot him an email, he's happy to do that. Let's see. There was one last question that I'd like to, we have about, a few more minutes. There was about the 6P and pleasure. And I should add that to the slide because I think pleasure is something we're almost afraid to tell young people, that sex can be pleasurable, because then they're going to want to go out and do it. Right. And I think that's, again, a hurdle that we have to get over. The prevention, et cetera. If sex was so terrible, then why would we want to do it? And I think letting them know that it can be pleasurable, should be pleasurable. And here's how the things that you can do to maximize your health, et cetera, so that it can be that, right? And not have the consequences. I think we as a community have to be more comfortable being able to say that. Were there other questions? That's all the questions that came up in the chat. I wonder if people have other questions that they had for me or have for each other to talk about. Now that you have me, I'll be quiet. Unless you ask me something.
Well, I just wanted to mention too, we have clients in the clinic from different cultural backgrounds and also from other parts of the world, and you have to be very sensitive to how you approach some of those questions, because I have some clients who are female from Africa. They will not talk to me. They will talk to the female nurse practitioners or one of the case managers that is a female nurse, but they will not speak to me. And sometimes you have to be cautious whenever you're not getting answers, because it might be their cultural background not to talk to the specific gender or whatever about what's going on in the bedroom.
Yeah, I think you're absolutely right. And certainly it was mentioned before about using your extenders, and we have MAs and nurses, et cetera. And so if everybody's sort of asking the same questions, and we also have the surveys or other tools that we're using, we're hopefully somebody's gonna pick up the information and run with it. We have an increasing immigrant population from West Africa, as well as from Russia to our clinic. And depending on where you're from, culturally, you're right. There are just some things that you're not going to talk to either a different gender provider, or you're not going to talk to anybody about because they're taboo, and recognizing that. And it may take multiple approaches and, to do it, and different team members. But good point, knowing your clientele and knowing that there maybe need to be different approaches to take. All right. Any last burning comments, questions, concerns?
This is like a quick one. I'm sorry, but yeah. I know this isn't the meth group, but I do see, especially in a lot of my young MSM, a lot of meth use and high risk sex. And I'm struggling for a good screening question. I know we're talking a lot about questions, but how do you screen for meth use and with sex, and what particular question have you found to be the best in unlocking sort of the information that we hope to get from that?
Yeah, that's a good question. I mean, sex, drugs, and rock and roll is we always ask about that. Certainly one of the things I do ask is, so when you have sex, are there certain things that you like to do around sex, right? So you open it like that. And what do you mean? Some people like to do this or that, some people, and then so you sort of run through a list and you say, oh, well, what do you mean? Well, some people like to smoke weed before they have sex. Some people drink, do you find, and then if they do, not, but tell me, what does that make you feel, this or that? And, or your friends, your partner interested in having you do certain things around sex. So you may take it off of them and say, are there things that, you find your friends are doing, et cetera, and they're more likely to talk. Sometimes they won't, but, you ask it enough and you be permissive enough and okay enough in your facial expressions, et cetera, you may get it. Okay. So it's asking, questionnaire, you, the nurse, everybody asking it to try to garner it. All right. I think that's it. This was fun. I always worry about Zoom platforms and whether or not we're going to be able to do it. Thank you guys for listening, your feedback, your energy. Thank you for being interested in adolescents and trying to make sure we can make them healthier and happier. And I look forward to seeing you else in other conferences and other places. All right. Take care, everybody.